All right, well, welcome back, everybody, to Ultrasound Grand Rounds this week. Pretty excited to be back and bringing part 2 of the FAST exam. So last week we started out talking about trauma, some of the basics of trauma ultrasound. We're going to finish up the trauma exam today, doing part 2 today. And so without further delay, let's head on over to the trauma exam part 2. So if we remember from last week, we talked about basically the history of the FAST exam, how we got to using it in trauma, how the ED got to owning this thing, and then where it fits into the trauma assessment. And so we talked a little bit about the ATLS protocol and algorithm for trauma, and how the ultrasound really fits nicely into that primary survey for patients who are critically ill, and helps us identify where there is potential bleeding, because bleeding is one of the major causes of mortality in trauma. And so we talked a little bit about kind of that paradigm, like as we fit it in, like how it replaces the DPL, and how it could be a useful adjunct to the primary survey, and how it doesn't supplant necessarily further workup for other injuries. So that's kind of the big picture philosophical thing. But we said, hey, we're looking for a number of things, right? We're looking for hemoperitoneum, hemopericardium, hemothorax, and even pneumothorax, right? And how we can utilize kind of this, set of questions that we're trying to answer to really get into looking at the different components of the FAST exam. So the hemoperitoneum is covered in the abdominal FAST, hemopericardium is covered in the cardiac FAST, right? And we also look at a little bit about global function, talk about that last week. And then today we're going to talk a little bit about how we can use the thoracic portion of the FAST to look for hemothorax and pneumothorax. But before we get into that, I just wanted to review a little bit from last week in case you weren't able to be at last week's lecture and hear that. And also just as a reminder, last week's lecture will be posted on the YouTube channel. So if you do want to go back and watch the whole thing, as opposed to just watching this little review, you'll be able to go back. I haven't posted it yet, but it will be up soon. You'll be able to go back and watch the whole thing, and kind of all the expansive detail that we talked about last week. But just by way of review, the abdominal FAST really consists of, or is comprised of 3 specific windows, right? The right upper quadrant, left upper quadrant, and the pelvic window. Now you say, hey, there's 4 windows. Yes, part of that's the cardiac FAST. But the component that's looking specifically at the abdominal cavity, the peritoneal space, is these 3 windows: right, left upper quadrant, pelvis, right? And so the right upper quadrant was typically comprised, let's see, there we get some labels there, of the liver and the kidney, that interface in Morrison's pouch between the liver and the kidney. And you can see the diaphragm, kind of give you some other contextual clues there. And so fluid tends to collect when we look in this window in the areas marked by blue here. So the caudal tip of the liver, in the Morrison's pouch, less so in the subphrenic space, and definitely in the pleural space, you can see some fluid. So here's some examples of fluid kind of in that right upper quadrant. See, on the left, we have it surrounding the liver, right? And on the right, we have a little bit in the Morrison's pouch, and that bottom right is in the around the caudal tip of the liver. So that's an example of a positive right upper quadrant FAST exam, right? And so moving on to the left, we can see kind of our normal anatomic landmarks are going to be, again, marked by the spleen, right? The diaphragm, the kidney, right? And in contrast to the right upper quadrant, the left upper quadrant, you're going to more commonly see fluid in that subphrenic space, right? But you can also see it in the splenorenal fossa. And then again, we're going to talk a little bit today about the thoracic, how you can see it in the pleural space if you look above the diaphragm. So here's an example of a positive FAST. On the left upper quadrant, we can see fluid kind of in that subphrenic space between the diaphragm and the spleen. And then you can see an example of the fluid here at the caudal tip of the spleen, kind of heading into that splenorenal fossa, right? And the final part of the abdominal FAST is that pelvic window. I like the sagittal orientation of the pelvic window because it gives you a nice view up into the peritoneum, right? And we're looking for, in a female, a bladder and a uterus, and look for fluid kind of surrounding that uterus. And in the male, obviously, we're looking for just the bladder and the fluid kind of above or cephalad to that bladder, right? And the place where it's going to collect is going to be in this retrovesicular space, or the pouch of Douglas, kind of over by kind of anterior to the rectum, in the intraperitoneal space on the left side of this screen. So here's an example of a positive pelvic window where you can see that free fluid that's outlining the bladder here. And in this example, it's a little less visible, but you can see free fluid kind of surrounding the uterus. It's clotted free fluid, kind of anterior or cephalad from the bladder, right? And so it's an example of that. So the next part of this is the the cardiac portion of the fast. And we talked about that last week. And that's the additional, that fourth window in the traditional fast exam, where we're looking to see basically two things. Right? Is there fluid kind of surrounding the heart in the pericardial space, right? In the setting of trauma, it's assumed to be part of the trauma. And then is that heart beating, yes or no? You can nuance it to how well it's beating, but really in the setting of the fast exam, is it beating and how much fluid's around that heart? And so here's an example of the subcostal window, right? You can do it in the subcostal window or the parasternal long axis. But in the subcostal window, it's just below the costal margin, looking up at the heart, and you get a nice, decently four-chambered view of the heart. So adding a little bit of labels here, you can see the pericardium in the gravity-dependent area, kind of posterior to the heart there, as well as see the liver in the near field. Those are kind of some of the landmarks that you're looking for as you're looking for fluid kind of that collects in that pericardial space. And so giving you a little bit more anatomic information here. Here's the different ventricles, so LV, RV, LA, and RA in this particular heart. And so we're looking kind of in that gravity-dependent area for anechoic or sometimes echogenic material that lives within that pericardial sac that may be abnormal as a result of the patient's trauma, right? Now we can go up to the parasternal long axis. So when you don't have a subcostal window that's working for you, right? You can go to the parasternal long axis and get a lot of the same information from just a different angle. And so here, just to add some anatomical landmarks, we can see the pericardium kind of in the far field here. Again, that's a gravity-dependent area because it's a posterior pericardium. And then you can see the descending thoracic aorta, which is in this situation just kind of cut off on the right-hand side of the image here, which is going to be just deep to that left atrium. That's the key landmark that we're going to use to identify an effusion as pericardial versus pleural, depending on how it interfaces with that descending thoracic aorta. There's the arrow that we show that with some different labels on the chambers here for us to help get some further orientation to this image. And so if we want to look at some pathology, here's an example of a pericardial effusion in a patient. So you see the four chambers is a subcostal window, and you see some anechoic fluid that's circumferential to the heart that's still there throughout the entirety of the cardiac cycle, even when the heart is in full, large diastole, right? And you can even see some undulation of that our right ventricular wall throughout the cardiac cycle, which is suggestive that this effusion not just exists, but it's causing some hemodynamic forces on the right heart, which would be suggestive of early or impending tamponade in this particular case. And so those are the four windows of the traditional FAST exam. And so if you read the early literature, kind of look at some of the textbooks, that's going to be the basics of the FAST exam. Now, what happened over the years, we say, hey, this is a great tool. Can we expand this to other questions that we may have in the trauma setting? So if you go back and think big picture to what are my priorities in trauma, right? I get a patient on the table, EMS brings them in, they tell me, hey, this is what happened to them. They have a blunt or penetrating injury, whatever the case may be, and they're hemodynamically unstable, right? As part of my workup, I'm going through this primary survey searching for potential causes of their hemodynamic instability, right? Or potential life or limb threats that I need to intervene upon right now that I can't defer until later, right? And so the first question is, well, why are they hemodynamically unstable? Because I need to intervene upon that because that might be getting worse. And the goal is to find that, stop and fix that to the best I can before I move on and then identify, the fact that they got their pinky toe fractured as a result of, whatever their trauma might happen to be, right? And so in this setting, we generally tend to think of massive exsanguination as the major one, but then all of the obstructive phenomena, right? So if you have a tension pneumothorax or a tension hemothorax or a pericardial tamponade, those are big things that need massive drainage early on in the patient's trauma resuscitation. That's going to have a massive impact on their mortality and their morbidity. And so these are things I need to identify. And so the question was then asked is can the ultrasound help us try to identify more of these different things that can then intervene, that I can, decide to intervene upon in the trauma bay? And so with that kind of question, as the framing, then, we came back and said, hey, look, the ultrasound can help us find, if there's problems in the thorax. We can find hemothorax, we can find pneumothorax, and that might help us identify some of these patients in extremis earlier in the trauma resuscitation. So that's going to be the topic of today's conversation with the thoracic FAST, right? And so the goal of the thoracic FAST is to evaluate for pneumothorax and thoracic free fluid. And I'm just going to take a quick aside here and say, one time, or a lot of the questions that I receive from people are like, hey, where do I start first? How do I implement this in a protocolized or algorithmatized fashion? And my answer is always like, well, typically the right upper quadrant is just the easy window to get because you're there and it's just comfortable. However, it really depends on what the patient is presenting with, right? And so they're presenting with penetrating trauma to the chest. It may be that we take this thoracic chest, book off the shelf earlier and scan that before we do the abdomen. Whereas if they have some blunt trauma to the abdomen, maybe I'm going to go to the abdomen before I come to the thorax. And so you can really mix and match the abdominal, the cardiac, and the thoracic portions of the FAST to really suit your clinical needs and do it in the order that you think would be most appropriate for your patients. So getting back to the the thoracic portion, we've identified the two things that we're trying to identify, trying to keep it simple in this exam is looking for pneumothorax, so air where it's not supposed to be, or hemothorax, blood where it's not supposed to be. And in the setting of trauma, we assume it's from the trauma until proven otherwise, right? So, again, a couple assumptions that we need to get out of the way. Looking for evidence of tension pneumothorax or large volume hemothorax. This is what we're trying to do, right? And so if there's, we still have to interpret this somewhat clinically, right? And so if we see a pneumo, right, we can't always assume that, hey, this is tension physiology. Maybe we have to in the certain clinical scenario, but like we may find things, but we have to continue to look and see if there's other things that we may also want to find, right? And so finding it's one thing, right? But we also in our evaluation then have to evaluate for the size of these things, right? So is this pneumo clinically significant? That's somewhat of a clinical determination. That's somewhat of a sonographic determination. We'll look a little bit at that as we move forward in this, right? And then the other assumption is the presence of fluid in the thorax is assumed to be traumatic related until proven otherwise, right? And so you have someone come in, you scan them, they're hemodynamically unstable, you find a left pleural effusion, let's say. It could be that they've just got long-standing pleural effusion from their, lung cancer that's been in there, and so it could just be something that's normal, but you can't assume that when they're hemodynamically unstable in trauma. You have to say, maybe this is what's causing their demise. Let's fix that and let's and move on. But just like we talked about, ascites can mimic a positive FAST, other things can mimic a positive thoracic FAST, and so we have to kind of interpret that clinically, and then when in doubt, make the assumption that it's related to the trauma, right? And again, finally, if you see a pneumo or hemo, it's presumed to be tension physiology until you prove to yourself otherwise, either clinically or with other sonographic findings that it is not, and that something else is causing their instability. So, with those assumptions aside, let's move on and let's talk a little bit about the basic windows that we're looking for, right? And so there's, I guess, couple basic zones. You can divide it up left and right. So, on the left side, it'll be mirrored on the right side. But you want your posterior zones, right? So the right upper quadrant, window where you kind of look up into the thorax is the posterior zone. And then your anterior zones where you're looking kind of along the peristernal, line, a line that runs along the peristernal space anterior to the lung. And so which zone you use really depends on what you're looking for. So if you think about it, when you put stuff in the pleura, right, whether it be blood or whether it be air, it's going to follow the rules that gravity dictates for it, right? So if you put air in the thorax, right, it's going to rise to the top because air is going to be a non-gravity dependent, thing. And so we'll look in the anterior lung zones when the patient's laying supine, right? If you put blood in the thorax, right, it's a gravity dependent thing, right? It's going to fall to the bottom. And so we'll want to look in the posterior zones as this patient's lying supine in the bed right in front of us. And so what we're looking for determines on where we're going to go, right? But we're going to start in the anterior lung fields here. And look at what we can find here. So when you do this, you want to put your probe indicator cephalad towards the head. You want to do the long axis of the body, right? The sagittal orientation of the body, just to the side of the sternum, right? You're not going to see anything through the sternum, so put it kind of in the peristernal space, long axis. And I usually do it somewhere just kind of in the mid to upper chest, right? We're going to eventually move, and it's going to make it, we'll eventually look along the whole thing, but we want to just start in the mid to upper chest, right? And what I'm looking for, right, is I'm looking for ribs. And so you see on the right-hand side of this image, we see some soft tissue findings in the near field, right? And then I see a horizontal bright white line, right? And on either side of that, it's bookended by these two lumps with deep shadow posterior to that. And those two lump things are the ribs, right? And so it's going to be bony signature. You're going to have the reflection on the anterior surface. It's going to be deep shadowing deep to that. It's going to go all down towards the bottom of the transducer. And I'm looking for that bright line just underneath that. That's as my pleura. And so that's what I want to focus in on, right? And those ribs are going to provide me the context to know that I'm not only deep enough, but I'm looking at the right structures just underneath that. And so I'll start there and I look for some lung sliding. So here's an example of it just going live. And as the patient breathes, what I should see is some movement along that bright white pleural line. We'll start that again just to let you see it there. So as they're breathing, it moves back and forth, right? It's been called a number of different things, lung sliding, ants marching, etc. But it gives you that context of some motion, right? And if I see that motion, I know a couple things, right? Number one, the patient's alive and breathing, right? That's important. Hopefully my ultrasound isn't helping me diagnose that definitively and I can look at the patient and see that as well, but it provides some reassurance to augment my clinical exam. But secondarily, the other thing that it's telling me is at this point, right, the visceral and the parietal pleura are adjacent to one another. Because so what I'm seeing here is I'm basically seeing the movement of that visceral pleura next to the parietal pleura as it moves back and forth during inspiration and expiration. And if I insert something else in between that, I will separate those two layers and I will no longer see that lung sliding, right? If I put air in there, I'll no longer see the sliding back and forth of the visceral and the parietal pleura at this point, right? And the key is at this point because I can move somewhere else and I can, have different findings, right? But as I'm looking to rule in or rule out pneumothorax, I want to evaluate the places where it could be and look for this lung sliding or lack thereof, right? So again, putting some labels on here, we see the ribs, we see the pleural line, you can see the rib shadows, and then you can see that lung sliding as it moves back and forth kind of in that space, right? So kind of making that go live again. Here's that sliding that we were talking about, right? And so this is the key finding that I'm looking for in the anterior chest. And what I've learned to do through reading, studying, and also making some trial and error is when you find this, right? I'd said put it down in the middle of the chest, but then scan up to the clavicle, right? Then once you've done that, scan all the way down to the diaphragm, right? And so you're viewing the whole anterior chest. And it doesn't take long. You put it down, go up to the clavicle, great. You pause a second on each rib space. There's only a few of them, so it only takes you, 5 or 6 seconds. And you want to watch that lung sliding happen at each rib space. And if you do that, right, you can say that there is positive lung sliding at all those places, which means there is no pneumothorax in that anterior lung field, right? And where I've gotten in trouble is when I've just popped the probe on there and not moved it at all. And I've said, hey, there's no lung sliding at this space, but I've missed maybe a small apical pneumo that is probably clinically insignificant. However, it is a little bit embarrassing when you say there's nothing there and then the CT scan says, no, you're wrong. This is why we get CTs as opposed to listening to you when we do ultrasound. So when you want to do this, make sure you scan all the way from clavicle at the top, all the way down to diaphragm at the bottom and evaluate each lung space in between to make sure there's sliding, in that area, and then flip to the other side and make sure you see the same thing, right? So here's an example of what happens when you don't see lung sliding. So when you take air and put it between the visceral and the parietal pleura, right? You're going to separate that. And even though the patient may be breathing, there's going to be air in between the visceral and parietal pleura. And so you won't see that that visceral pleura. You'll see the parietal pleura, right? But you won't see the visceral pleura because you have the air that's intervening there. So you will get a lack of lung sliding. And oftentimes what I see, and we see it in this image, is an exaggeration of the horizontal reverberations, those A lines that we see kind of at equidistant from, starting at the pleural line and then moving into the far field. And you want to know more about those horizontal A lines, go back to last spring, we did a 3 or 4 part series about lung ultrasound on the YouTube channel. You'll see that over there. You can see some of the more in depth about lung ultrasound on those videos. But this is what you'll see with a pneumothorax, right? You'll have a lack of lung sliding. And as you scan, you'll see that in various different places. Now, the question then becomes, what happens at the interface, right? Where, okay, let's assume the pneumothorax is small to medium size, right? It doesn't encompass the entire thorax. What happens at interface where you begin to have that pneumothorax, right? And this is something we call a lung point, right? And so it's the point where you see sliding in one area of the pleura and no sliding in the rest of the pleura, right? And so it's the point where the visceral and the parietal pleura begin to separate. And in the context of pneumothorax, it's beginning to separate because of that pneumothorax, right? And so this is the one sign that's been significantly positively correlated with the presence of pneumothorax, right? And so this is kind of what we're looking for as we scan. If you have no lung sliding, then we're kind of moving to different areas on the chest. Usually I go up and down the anterior lung fields, and then I come out laterally, right? So you get to the anterior axillary line, the mid-axillary line, the posterior axillary line, wherever I need to go to start finding where I have this lung point to really start defining the boundaries, how big this pneumothorax happens to be, right? And so this is what I'm going to do to help me find that pneumothorax. Now, the question you may say is, well, great. How good is this, right? How well does this perform when we're looking for pneumothorax, right? Is this something that's just like, you can do it because you love ultrasound, but whatever? Or is this something that is a good test that I should really consider to add into my armamentarium of tests that I have at the bedside with the trauma patients, right? So a couple articles I wanted to point out. So this one was published by Mike Blivis. It's been a while, but he basically published the ultrasound compared to chest X-ray, the supine chest X-ray in the setting of trauma, right? And he found that the chest X-ray woefully underperformed for looking for pneumothorax compared to the ultrasound. So the sensitivity, the chest X-ray was about 75%. Specificity, when you saw a pneumothorax in a supine chest X-ray, is high, right? It's about 100%, which is great because, it's the suboptimal test, but the specificity is kind of where things were interesting. So the specificity for the ultrasound outperformed the specificity for the chest X-ray in these. Let me rephrase that. The sensitivity for the ultrasound outperformed the sensitivity of the chest X-ray. Right, the specificity was pretty comparable, like 99.2% versus 100%. So the way to interpret this is, if you see a pneumothorax on either of them, you're probably good to go, right? If you don't see a pneumothorax, right, on the chest X-ray, you still have some digging to do because you might have something small, right? If you don't see a pneumothorax, if you don't do it well, like I talked about here, if you don't see a pneumothorax on your ultrasound, the sensitivity of that is significantly better with ultrasound. It's 98% compared to your X-ray, and so it's a pretty good test to help you rule the thing out, right? There's another study, we can go on to this one here, another study that was published looking at the lung point, right? This was one by Daniel Lichtenstein, where he looked at a number of patients and said, hey, how well does this lung point correlate with pneumothorax? And he found that the lung point had a sensitivity of about 60% and a specificity of 100%, right? So if you're looking for a lung point specifically, right, if you see it, you're pretty convinced, 100% convinced that this is a pneumothorax, right? If you don't see a lung point, you, again, still have some working to do on that sensitivity side. And here's another article published in 2012, Journal of Emergency Trauma and Shock, which basically reports the same findings as high specificity for that lung point. When you're scanning for these patients. So this is one thing I like to look for and say, can I find, if I don't see lung sliding, can I find that lung point, right? And then can I map that out and show me where the boundaries of this thing is? In fact, this article was referencing a few other cases where they can say you can actually map this out with pretty good accuracy compared to CT scan of how big a pneumothorax is. So you can say, oh, I got a small apical pneumo, they're hemodynamically stable, I don't need to do anything, versus I have a large pneumothorax and pretty much everywhere I look, they're hemodynamically unstable. We got to go. We got to get this stuff done. So anyway, that's just a little bit of an understanding of the pneumothorax. Now the question is, how do we document this, right? And so saving clips is a great way to do it. Another little hack or way that you can document this is use something called M mode, right? So that's the motion mode inside the ultrasound where you can put a line through a specific area and look at motion over time, right? And so this has brought up what we've called and what we've termed the sandy beach sign. So if you put M mode through the pleural line, right, and then turn it on, normally what's going to happen, you're going to have movement of the lung back and forth, right? That movement's going to be translated into this very granular appearance in the far field here in this ultrasound M mode that represents kind of that movement. If you have something that's static, that's not moving, it's going to cause that linear, streaky appearance that we see in the near field, right? So in the near field here, we have the chest tissues that aren't really moving all that much. We have the pleural line. In the far field, you have kind of this granular appearance. And this is normal, right? This is what you normally see when you do an ultrasound of the chest. And we've termed it the Sandy Beach sign, largely because you can imagine, if you kind of squint and stare at it, that the striated lines represent the waves kind of crashing in on the beach, and that gritty, very granular stuff that's represented by the movement of the lung kind of correlates with or looks like sand that might be on the beach. And so hence the Sandy Beach sign. So this is a great way, either to confirm, right? You can put that line through there and see I have Sandy Beach or not. And also, if you can't save still images in your study, you can do this and save a static image that represents the dynamic motion, showing the Sandy Beach sign there. Now, the question is, well, that's great if you have it. What does it look like if you have a pneumothorax where you have no lung sliding, right? And we call that the barcode sign, right? And so you can see if there's no movement above or below or at the pleural line, everything is going to have that kind of striated appearance, right? It's going to just be streaky all the way across the screen. And this is going to be what we call the barcode sign. Some people call it the stratosphere sign, but the barcode sign is traditionally what I've referred to it as. And so both of these can be helpful, not only just to document, but also to help augment our view and communicate, hey, this is what I'm seeing, to myself, to the people around us, and the people who are going to come look at our study after that, once we've essentially documented, right? So that's the evaluation for the pneumothorax, right? Just kind of going back and recapping on that one. When we're worried about air in the pleural space, we're looking specifically for movement of the visceral and parietal pleura at the pleural line in the least gravity dependent area, the place where the air is going to collect, right? And so if we see movement there, right, we know that there's no air between the visceral and parietal pleura, right? And so we know that at that space, there's no pneumothorax. And now we just have to evaluate all the other the least gravity dependent areas to make sure there's no movement there, right? If we see a lack of sliding, right, then that suggests that something's preventing that. And in the context of trauma, we assume that this is going to be air. And then we want to see how big the thing is by scanning up and down in the anterior lung field and then moving out laterally to see how far laterally we can go until we hit a lung point where we see that interface between the visceral and the parietal pleura, right? And so that's the basic recap of pneumo. Now, the question is then, great, what about if we have a hemothorax, right? What if we're bleeding into the chest or have fluid in the chest? And so that brings us to part B of the thoracic exam, and that's the evaluation for hemothorax. And so this gets us back originally to kind of brings us full circle back to where we started with the right upper quadrant and the left upper quadrant views. So we talked about that last week. But last week's focus was looking for fluid below the diaphragm, right? This week, what we want to talk about is looking for fluid above the diaphragm. In fact, there's a really good study that I read years ago that divided up the different components of the FAST exam and said, what's the most commonly positive portion of the abdominal FAST exam, right? And I know this is abdominal, but what was interesting is they divided the left and the right into three lung zones, right? R1, 2, and 3, or three zones, right? R1, 2, and 3, and the left into L1, 2, and 3, right? And they corresponded with, around the diaphragm, in those pouches, and at the caudal tip of the liver, right? And this is all subdiaphragmatic, right? Now, so what that's caused me to do is, in my practice as I scan, is really, when I look at these windows, right, look at these spaces, I take it in three chunks, right? I want to look up at the diaphragm. I want to look at Morrison's pouch. I want to look at the caudal tip, right? I look on the left side, I look up at the diaphragm, look at the splenorenal fossa, look at the caudal tip, right? Really just breaking that into three different parts, potentially three different images if I can't see it all in one. But that focusing on the diaphragm, not only am I focusing at what's under the diaphragm, but I'm also looking at what's right above the diaphragm. Because I know that if I have a patient laying supine, right, or even a little bit in reverse Trendelenburg, so head of the bed up a little bit, gravity is going to pull the fluid, kind of the posterior aspect and inferior aspect, and start collecting at that costophrenic angle that's going to be visible from that right upper quadrant or left upper quadrant window. And so this is an example. This clip here shows me kind of where my probes need to be on the patient's body, but also what I'm looking for, right? I'm looking for that liver, that bright white diaphragm, right? And then the stuff above it, right? And there's a few things that I've learned, and I'll just go to this image just to make it a little bit bigger. There's a few things things that I've learned over the years that I have to be really, really careful and really, really mindful of, right? And those are identifying specific anatomic structures, right? And we'll put some labels on that here and see what I'm looking for. So number one, the hard one to miss, and we're going to talk about the right upper quadrant. The same things apply to the left upper quadrant, just, insert spleen here instead of liver, right? But I'm looking for the major organ system, right? That liver or that spleen, right? And then what I want to identify, the next thing I want to identify is the diaphragm immediately above it, right? And so I've had a few cases where we've had to stare at it, it's been, questionable where it is. And the key in those cases is identifying that diaphragm. It should be a bright white line that lives right on top of the liver and right on top of the spleen. And sometimes, particularly in the spleen, when you have subphrenic fluid, that fluid can peel that diaphragm away from the spleen or push the spleen down from the diaphragm. And so you have to be really careful that there's not a second line a little bit further up, that you'd positively identify that bright white line as the diaphragm, right? So that's the key, identifying the diaphragm, right? And then what I'll look for is the lung above it, right? And so if you put fluid inside the thorax, it's going to crowd out the lung for space, right? There's only so much space that's inside the thorax. Generally, as we breathe, the lung will aerate, right? We get air down into the alveoli, and as we do that, it expands, and that lung expands to fill the entirety of the thorax, right? But if you put fluid in there, right, that fluid is going to compete for the air, right? And the fluid's less compressible than air, and so it's going to stay in there, and the air is just the air-filled lung is just going to give way to the fluid, as they compete for volume. So the fluid is going to push that lung kind of cephalad. And you're going to see some consolidation of that lung as it can no longer expand into that fluid-filled space, right? And so in this view, we see that lung that's consolidated, that's pushed up, kind of like a flag or a pendant on the left-hand side of the screen inside that hemothorax, right? So that's anatomy part number 2, right? I want to look for the diaphragm. I want to look for the lung, right? And the third thing that I'm looking for, if it's a large enough thing, is these vertebral shadows, right? Because I'm going to start seeing those as we fill the thorax full of fluid, right? And so the theory or the physics behind this is air obscures the transmission of ultrasound, right? Ultrasound doesn't transmit well through air. And so whenever you put air somewhere, it's going to block the view of whatever is deep to that, right? Whatever is in the far field. When we have lung fully filling the thorax, right, it's going to fill up, and I'm not going to see the vertebral bodies or the vertebral shadows, which are deep to that lung. But as I fill that thorax with stuff that's echogenic, right, that transmits ultrasound, or in this case, I guess anechoic, but things that transmit ultrasound, and displace the air out of the way, I'm going to start seeing far field structures that I wouldn't ordinarily have seen. In this context, for the vertebral bodies or vertebral shadows. And so this is another identifier that I'm looking at fluid in that thoracic space, right? And so those are the 3 major anatomic things that I'm looking for. And again, if you want more detail, go over to the YouTube channel. We've put up some videos about lung ultrasound, specifically about putting fluid in the hemothorax and kind of the various different things that you can find and different, there's like 5 or 6 different findings that would suggest that. Go over and look on that video. But that's kind of what I'm looking for when I'm trying to identify, is there fluid in the setting of trauma? Is there hemothorax kind of in this space, right? And so we're looking for fluid kind of right here in this posterior costophrenic angle, as we're scanning through the patient, right? So here's an example of a trauma patient where you can see the left upper quadrant, right? We see the spleen, and then you can identify that positive, bright white line. In this case, you see it deep to the spleen, right? But you can see how it's coming up to the spleen, and just to the left of that, right, is this little triangle of anechoic fluid that represents the pleural fluid in this patient's left hemithorax. And so that's going to be an example of a positive thoracic fast looking for fluid in that hemithorax, okay? So with all of that clinical understanding of what we're looking for, what it looks like, or a sonographic understanding of what we're looking for and kind of where to find it, how to get it. The next question is then, well, how do we integrate the FAST exam into our practice, right? And so how do we understand this context? We get these trauma patients into our ED. How do we deploy this test to get max benefit so we're not being redundant with things and we're providing some positive benefit to the patients, right? And so as we evaluate our patient, right, they're coming in, we're doing our primary survey. We're asking ourselves, a number of questions. What's their hemodynamic stability? We're saying, is there any like penetrating trauma to the thorax or to the abdomen, right? And as we start thinking, like, do we have a concern for like a pneumothorax, or do we have a concern for an injury with free fluid? And if we start answering yes to some of these questions, right, there's hemodynamic instability, we have penetrating injury to particularly the chest, but also to the belly, we have concern for pneumo, have concern for free fluid injuries, then we start thinking, okay, we need to start deploying the FAST exam to identify this, right? And so, the findings from there was going to dictate then what we do next, right? And so, when we think about the abdominal portion, right, we have, abdominal FAST positive, abdominal FAST negative, right? If the patient is hemodynamically unstable with a positive FAST, traditionally, right, that has meant the patient needs to go to the OR for an X-lap and an evaluation for where this hemodynamic instability is. Because the presumption is if it's positive FAST in the belly, they're bleeding into their belly, right? There's a problem there. Now, this has over the years become more of a nuanced question, right? And I'm going to kind of leave it as such in the context of this forum. We've had ongoing conversations with our trauma surgeons about this as new and different technologies emerge and as we identify where bleeding comes from. And so there's certainly a lot of nuance. If they have a splenic laceration that's causing the bleeding, that means one thing. If they have a hepatic laceration, that means another thing. If it's penetrating versus if it's blunt. So obviously this needs to be evaluated and assessed by a trauma surgeon. But if you're taking the boards, right, traditionally speaking, hemodynamic instability in the context of positive FAST goes to the OR, right? If they're hemodynamically stable or stabilizable or stabilized with a positive FAST, now the question then becomes, okay, what's bleeding, right? And what's going to be the most appropriate treatment, right? And this is where kind of that nuance gets a little bit muddy and requires a lot of, clinical understanding of what's going on in the patient and kind of what your capabilities are at your center, right? And so oftentimes these will go to CT scan to identify further injuries to see exactly what needs intervened upon, if anything, that's causing the patient's hemodynamic instability, right? Now, in the context of a negative FAST, well, what does that mean, right? Hemodynamically stable, negative FAST, you still have to go to the CT scanner. Like we talked about, do these patients have, or can we rule out all injuries with the FAST exam, right? We talked about that study last week that suggested the FAST exam looking for all injuries, right? All injuries is the key, has about a 30% sensitivity. So we know that the test is not optimized to find little omental things or mesenteric things. It's going to find free fluid and that's about it, right? So if your injury is not associated with free fluid, the FAST exam is not going to be your test of choice, and you still need to do further imaging, right? But what is helpful in this context is you say, okay, I got a patient who's hemodynamically unstable. The abdominal FAST is negative, right? We can make maybe a little bit of an assumption saying, if they're hemodynamically unstable, and the problem was coming from the belly, right, I should see a significant amount of blood in the belly, right? Because we presume that hemodynamic instability is from massive volume loss, right? And so I should see massive fluid in the belly. So if it's negative, doesn't rule out all injuries, right? We still have to kind of have a little bit of a suspicion, but it tells me I need to move on to a different cavity to look for a significant enough injury to cause the hemodynamic instability. So that's indication for me that I need to search for other causes. I need to move on to the cardiac FAST. I need to move on to the thoracic FAST. And keep a clinical eye out for the patient, right? So with that said, let's move on to the cardiac, right? So what do we do with a cardiac exam if it's positive, if it's negative, right? So if we have a cardiac FAST in the patient's hemodynamically, or a positive cardiac FAST in the setting of trauma, right? And they're hemodynamically stable, the concern is that this fluid is coming from the heart, right, from the trauma, and that they will rapidly decompensate and become hemodynamically unstable. And so there needs to be definitely a thought towards this patient going to an operating area to get this drained. And further assessed, right? Now, there may be some little asides if they're hemodynamically stable, but it needs to be a patient of high concern. Now, you could say, well, what if they had an effusion previously, and they come in, having, a minor car wreck and now they have an effusion again. Yeah, we can nuance that a little bit. I think that's a good discussion. We've talked a little bit about that on this forum with our trauma folks. But I think that you need to have just kind of this reflexive thought that unless there's any other glaring things saying otherwise, positive FAST in the cardiac, in the setting of trauma, you really should be thinking towards the OR, right? In the hemodynamically unstable, it's just not even a thought anymore, right? They need to have that drained. And if they got pulses, if they're talking, they're looking at you, let's get you up to the OR as quickly as we can so we can find out what's going on, get that drained so you don't, progress from like a fulminant tamponade into like a cardiac arrest, right? And so you kind of turn up the timeline a little bit on the hemodynamic instability. Okay, negative FAST. What does that tell you in this patient who's experienced some trauma? Well, if they're hemodynamically stable, again, going off to look for other injuries. If they're unstable and they have a negative FAST, right? Cardiac FAST, so no fluid in the pericardial space, you need to continue moving on to the other compartments, the belly, the thorax, the rest of your clinical assessment to see what's going on with this patient, right? As an aside, one little quick reminder, especially for some of our trainees who may be watching, positive FAST in the setting of trauma who's hemodynamically unstable. What we were going to want to do in the emergency department is we're going to want to control as many things as we control, which means flood them with fluids, hopefully blood, and manage an airway. I would argue that in this situation, managing the airway is probably not something that we need to do, rather get them up as quickly as possible and let anesthesia do that. Because if we convert the patient from a negative intrathoracic pressure to a positive interthoracic pressure, all we're doing is making their tamponade worse, and we're going to precipitate untoward events in this patient. And so if at all possible, we want to avoid intubation of hemodynamically unstable patients with a positive cardiac FAST in the setting of trauma, right? So a lot of if, so that we don't make them worse and really try to, augment their normal functions as much as possible until we can get up to the OR, get it done right away before the surgeons can go open up that chest. And so that's my little aside. Let's move on to the thoracic FAST. So we've talked about the belly FAST, the cardiac FAST, how we integrate those into clinical practice. The final one is the thoracic FAST today. The pieces that we talked about today. And so again, if they're hemodynamically stable, right? If you have a positive thoracic FAST, if you have if you have a pneumothorax, and this is this context we're talking about here, a pneumothorax, and they're hemodynamically stable, the next thing to do is how big is this thing, right? If it's super duper big, okay, it's probably gonna need a chest tube, right? You can kind of take a breather, maybe slow it down. You don't have to rush this thing in there. Get your nice sterile prep, just do it, get it done right. If it's not big, right, if it's super duper small, then this may be one that you just want to note and then just observe and make sure that there's no further, hemodynamic changes with this patient, right? If they're hemodynamically unstable, positive thoracic FAST, right? You have a pneumothorax, they're hemodynamically unstable with either air or blood, right? They need a chest tube. They need that drained to see if it's causing tension physiology. And you relieve that tension physiology through your, finger thoracostomy first, through your chest tube drainage thereafter. And then obviously there's all the considerations and trauma of, how big is this thing and how much, blood comes out of this thing, and does that then predicate the patient to go to the operating room looking for active ongoing bleeding? So a lot of questions to answer there, but unstable, positive thoracic FAST, chest tube, right? Negative thoracic FAST, right? You see no fluid, you see no blood, they're hemodynamically stable. Again, we're going to send them down that route to look for other imaging. Other assessments for what could be going on based on the patient's clinical presentation. If they're unstable, again, it gets to we're starting to see a theme here. If they're unstable and they have a negative FAST, you see normal sliding everywhere, you see no blood in the hemithoraces on either side, then you need to move on. You need to look for some other cause in the abdominal, cardiac FAST, or other clinical things. Do they have a head bleed? Do they have blood in their thigh? Do they have a bunch of blood that's leaking on the floor? What are the other causes for potential hemodynamic instability in this patient in the trauma bay? So that's kind of the general idea of the FAST exam, right? We talked a little bit last week, just as a recap, about the abdominal and the cardiac FAST, what you're looking for in those settings. We looked at some normals, we looked at some abnormals, and then today we rounded it out with the thoracic FAST, looking at the use of ultrasound to evaluate for hemothorax, looking for pneumothorax, see if there's anything that we can identify there and how to interpret that in the clinical context. And so I'll leave you with this image, just kind of showing the whole thing all at once. Where we can see they're different almost like I like to consider them like books on the shelf, right? You have the 3 different books. You can mix and match. You can use the different windows to give you the answer that you need for your specific patient. So as you're looking for things like hemopericardium or hemoperitoneum or pneumothorax, we're going to use the FAST to find these different things. So left upper quadrant here, we see a positive abdominal FAST. Right upper here, we see the positive cardiac FAST. Left lower, we see, is there lung slide or not? Right lower, we're looking for, is there fluid in the hemothorax? And so that is rounding out the entirety of the FAST exam. And with that being said, I'll take any questions or discussion points that you guys might have. So anything I can answer for you, any questions? All right. Well, if there's no questions, I think we'll kind of wrap things up here today. Thank you guys for joining today for today's Ultrasound Grand Rounds. I always enjoy giving these kind of researching topics, talking a little bit about it, and using it as a tool that we can use to kind of go back to and kind of learn this stuff and teach this stuff over and over again. So if you have any other questions, let us know. Otherwise, this ultrasound lecture is going to be posted on our YouTube channel here shortly, along with all the other ones, where you can go back and look at the first part of the FAST exam, this part of the FAST exam. We got some other lectures on the FAST exam and all the other components of ultrasound. So go back, check that out. MetroHealth Emergency Ultrasound on YouTube. Hit that subscribe button so you can see, have it in your feed and get notified when other videos get posted. And for those of you guys that are here, we're going to have this forum again in 2 more weeks. We'll be talking a little bit about the cardiac exam and how we can use that to assess patients in the emergency department. So we'll look forward to seeing you guys in 2 weeks for the next installment of Ultrasound Grand Rounds. Thanks for being here, guys, and we'll see you next time.